Good morning, everyone. It's my pleasure to be invited to Vietnam Society of Radiology and Nuclear Medicine to share my experiences of traditional versus microembolization for HCC. I'm B. Zhang, currently serving as the Director of Radiology Abdominal Imaging Department in Taichung Veterans General Hospital in Taiwan. In my 10 years of experience as an attending physician, I have handled many difficult cases of CTAs and DEPTAs. Also, as a board member of the TSIR, it's always been on my heart to devote my times to educate and groom the next generations of young talent in interventional radiology. I hope that my sharing today will inspire more young doctors. As we all know that TACE is done by chemotherapy delivered in high concentration to enhance coagulative tumor necrosis. And then we will add some embolization agents to get arterial obstruction that can cause ischemia and resulting in tumor necrosis, thereby reaching a high rate of objective response. Also, we have to be aware that perfusion to uninvolved liver is maintained by the portal vein and permitting selective targeting of the tumor. So liver function is really important when we carry out TACE treatment. And the benefits of TACE in intermediate HCC. As we know, TACE is the most widely used treatment for unresectable HCC, especially for stage B, to produce survival benefits and a favorable response without adversely affecting hepatic functional reserve, so we can reserve the liver function and reach liver control. Lancioni had published a paper in 2016 indicating that objective response rate can reach 52.5%, and the overall survival rate in 1 year is 70%. And let's move on to the comparison of DTACE and CTACE. The DEPTACE is also known as the DEP-TACE, and it uses drug-eluting beads as microspheres. And for CTACE, we usually use the Lipido with chemo agents such as doxorubicin or epirubicin, and you added some gel foam to reach arterial embolization. And for preparation, DEPTACE is more consistent and more easily reproducible because for CTACE, we usually use a non-standard procedure that is dependent on the operator. And for drug release in DTACE, it is sustained because the release of the chemo agent will last for about 2 weeks. As for CTACE, it releases drug rapidly and can only be sustained for maybe less than 30 minutes before the oil and chemo agent separate. This means that it will increase the side effect. And for the material used, the drug-eluting beads stayed permanently, but for the gel foam is temporary, which will regress within 2 weeks. For particle size, eluting beads is about like medium size, while Lipido is in small size and gel foam cubes are in large size. For catheter positioning of the treatment, most of the time the DTACE needs to be in segmental or subsegmental superselection, while for CTACE, we can go with lower or subsegmental or segmental superselection. And don't forget that the injection rate for DEPTACE should be very slow to make sure the drug-eluting beads can go into the artery smoothly. And for embolizing the vessel, when using deptase, we usually embolize the artery. But for CTase, to reach a complete treatment, we usually embolize both the large artery and the portal vein. Also, remember the endpoint for deptase should be near stasis, whereas CTase should be complete stasis of the vessel. For the dose of chemo agent used in deptase, we can use up to 2 vials, meaning 150 milligrams of doxorubicin or epirubicin. But for CTase, we usually only use 10 to 50 milligrams of chemo agent. Let's take a closer look at deptase and CTase. You can see that the drug-eluting bead is medium size and usually ranges from 100 to 300 micrometers, while lipiodol is in small size and gel foam is larger. But yttrium-90 is much more smaller, about 30 to 35 micrometer. So don't forget that the size of the hepatic microvascular bed, because the terminal of the hepatic arterioles and terminal portal venules are within a diameter of 15 to 35 micrometers. So it's quite safe to use drug-eluting beads for the TACE treatment. The key is to choose the size that is larger than that of the microvascular bed to avoid complications. In catheterization, we should avoid catheter wedging because if not, we will have the reflux of drug-eluting beads and complicated the procedure. Most of the time, we do the embolization selective for 2 to 3 segments or super selections for subsegment. We can perform super selection, which means the curved catheter is positioned at the subsegment of the liver. And for ultra selection, it means that we usually reach the tumor feeding artery. And for the embolized vessel, when performing deptase, we only embolize the hepatic artery, and we cannot see the lipiodol retention into the tumor. But when we use CTase, we can see we usually embolize the hepatic artery and also the portal vein, and we can also see the lipiodol retention in the tumor and the portal vein since the lipiodol is radial packed under the fluoroscope. Have you ever wondered, is deptase more effective than CTase? Deptase may be more efficient in large tumor when the size of the tumors are larger than 5 centimeters, because for such tumor size, CTase is unable to treat completely. And theoretically, deptase has more sustained anti-tumor activity than that of CTase by releasing chemo agent doxorubicin hydrochloride consistently. And Precision 5 trial also reduces liver damage and produce less side effect by using deptase, particularly in large tumor. Actually, there are papers that claim that deptase are much better than CTase, while there are also papers that claim that deptase has almost the same effect as CTase on response rate. So, what are the differences? You can see that for the claim that deptase is better than CTase, the average tumor size is 6.7 centimeters. But for the claim that both have the same effect, the tumor size about half the size smaller. It's only 3 centimeters. So we can infer that when treating bigger tumors, deptase may be more effective than CTase. So size does matter. It determines which one we should choose. Depth taste may be more efficacious in larger tumors that are larger than 5 centimeters. Also, it reduces the chance of liver damage and gives less side effects. Moving on to kinking criteria. The TACE usually treats intermediate stage HCC, but within the subclassification of the stage B, also known as the kinking criteria, and you can see that if the tumor size and the tumor number are less than a score of 7, it implies that we can choose CTACE and we will observe good response. But if we have beyond or up to 7 criteria, it means that the tumor is larger or are more tumors than anticipated. Then CTACE cannot reach an optimal response. So we have to use that TACE instead to produce a better response. As you can see here, we have subgroups of the stage B HCC. If the patient is stage B1, we can choose CTACE. And if the tumor is large, then go with depth TACE. If the patient is stage B2, the tumor is larger than 6 centimeters, we should choose depth TACE. And if the subclass of the patient is stage B3, we have to perform superselective CTACE or depth TACE. And if we have larger tumor or more tumors, then we should carry out selective depth TACE to preserve liver function and avoid complication. And I would like to show some of my cases on depth TACE and CTACE. This is a CTACE optimal scenario. You can see it's lucky day for us because the tumor is only 3.8 centimeters in length and it's located in segment 7 of the liver. Thus, it's quite simple to treat it. We use 20 milligrams of epirubicin and mixed with 4 milliliters of lipido and some gel foam cubes. Over here, you can see that the lipido filling really well into the tumor, and we can observe the portal vein clearly, so we can expect a good response for this kind of treatment. And here is another CTACE optimal scenario. So you can see that the tumor is hypervascular and the lipido retention in the tumor clearly, and it indicated this is a good treatment too. And here is a case when we have really small HCC. In this case, the tumor is 2.9 centimeters located in segment 7, and another is much more smaller, only 0.9 centimeters located in segment 4. Don't forget, we can choose to use combined CT to assist us to reach good quality of the treatment. After carrying out combined CT, we can find a small caliber of this blood vessel supply and then do the embolization. So after using combined CT, located the blood vessel and do the super selection, you can see that the lipido reached the tumor really well. So it is a good response case too. And for the small caliber of vessels, when we are doing CTACE, you can see that the vessel here is really small, and we have done the TACE for 4 times, and we do the selection for each vessel to make sure that we can reach the blood supplying vessel of the tumor, and we choose a burn type microcatheter to this treatment. And after the treatment, you can see the lipoidal retention. And here you can see that after the treatment, the lipoidal retention is quite well. So this is also a complete response case. Moving on, here is a case of right inferior phrenic artery. We also performed CTAs to reach the vessel and to embolize the tumor. So we can easily choose the blood supply of right inferior phrenic artery. And you can also see the lipoidal retention. Let's move on to my deptase cases. We did deptase on small tumors, but you can see from here that we are treating this small tumor. We usually first do the DSA to identify the tumor stain, and then we did cone beam CT to locate the blood supplying vessel. Then we added drug-eluting beads to the specific vessel of the tumor. And we received a good response from this procedure. So you can see after the deptase treatment, we observe tumor necrosis, but we don't see lipoidal retention. Same for the small tumor. From a medium-sized tumor, we choose deptase because this patient has poor liver function. The bilirubin is up to 2.5. So after several treatments, the bilirubin didn't increase, meaning the liver function can be preserved instead of being damaged. So that's why I choose deptase for this patient. And for the larger tumor, we have this HCC in 12 centimeter long. And after 2 times of deptase, using 2 vials of 100 to 300 micrometer of DC beads, you can see the vascular lake formation. And I added a little bit of lipoidal to control the vascular lake. After the imaging follow-up, we observed the lipoidal retention into the vascular lake, but good tumor necrosis. And for this case, it is a very large tumor. It's up to 24.6 centimeter long. Over here, we can see that the whole right lobe is occupied by the liver. We did 2 times of deptase, and after the deptase, we observed decrease of the tumor vascularity, and this is a partial response of the tumor. To conclude, there are indicators which we can look out for CTAs and deptase. And the most important indicators are the tumor size, the number of the tumor, and the liver function. And for small size, I recommended to use small size of microspheres or simply just use CTAs to reach a more objective response. As for medium size of tumor, around 3 to 8 centimeters, I recommended using deptase as it produces a better outcome and less side effect. For large HCC, which are larger than 8 centimeters, we can opt for deptase as well because we can get better response while creating less side effects. And I hope my sharing brings some insights to your practice. Thank you.